Hello, everyone. My name's Dr. Caroline MacCallum, and I'm coming today from St. Michael's Hospital from the family room. Apologies. I had a friend, a family member end up in hospital. Uh, yes, apologies for my background, and it won't take away from the content that we're sharing today. So appreciate the patience. Today, I'm going to be doing a second talk on medical cannabis with a focus on chronic pain and central sensitivity syndrome. So there'll be a little bit of refresher in there for those of you in case you didn't attend the first talk, and then a lot of new stuff as well if you did attend the first talk. And both of them will be available through Dr. Arsenault's website, YouTube channel, so feel free to access them there. My contact information is on this slide, and I will also provide handouts that will be distributed to the audience. So I wanted to start today with a little bit of a case. And this is a 55-year-old female I saw many years ago, and she had a number of diagnoses in addition to namely fibromyalgia was how she was referred to me, and central sensitivity syndrome. But she also had some rheumatoid arthritis, osteoarthritis, cervical disc disease, and some radiculopathy, as well as other diagnoses that were not pain related. She had irritable bowel syndrome, thyroid disease, a blood clot, diabetes, and osteoporosis. Her symptoms, besides pain, were also nausea, which related to the pain, but also to some of her medications. She had depression and anxiety, which are commonly seen with chronic pain, as well as insomnia. And in particular, her trouble with sleep was staying asleep. So she could fall asleep, but she was waking up. And that makes a difference, as you'll see when we talk about what we might offer this patient. Her medications are very complicated and a very long list. Many of you may be familiar with a number of these, but I'll just run through them for the audience. Rituximab is a type of antibody given for rheumatological conditions as well as some other conditions. She had failed a number of other biologics, so that's why she was using that one. Prednisone, which is a bittersweet medication, it can be helpful, but it can also have a number of side effects for patients. Venlafaxine, also called Effexor, which she was using for anxiety and mood. Trazodone for sleep, but also has some antidepressant activity. Nortriptyline for sleep, but also has some role in chronic pain. It's a tricyclic antidepressant. Nabilone, which is the synthetic version of THC, so man-made THC, if you will. She was on methadone as she had tried hydromorphone and it wasn't working. So for some people, methadone or opioid rotations are something that we consider. Methadone is unique because, as you'll see in one of the slides coming up, it actually works on the NMDA pathway. So it's not a true like a regular opioid. It's a little bit fancier, but there's also issues with methadone as well, with prescribing and the government registry programs and so forth. Gabapentin, which pretty much everybody in this audience knows that medication, and sometimes it's a love-hate relationship, but for each person, they can have a very different experience with these medications. Zoledronic acid, which is for the osteoporosis, ondansetron for the extreme nausea, levothyroxine for the thyroid issues, metformin and insulin for diabetes, and warfarin for the blood clot. And she's also tried multiple nerve blocks, IV lidocaine. She might have also tried ketamine as well before I saw her. So pretty complicated patient here. Second, I'm just trying to advance this slide. There we go. So I want to start with this slide. I'm going to be weaving in some evidence as we're talking today, a bit more than I did in the last talk, which was a bit more of like a 101 or a primer, let's call it. So this one in particular is treatment goals that patients reported in this publication in the Journal of Cannabis. And you can see the title here, Consensus Recommendation on Dosing and Administration of Medical Cannabis to Treat Chronic Pain, Results of a Modified Delphi Process. I was actually part of this working group. And I really like this part because it's fine for us physicians to say, this is the number needed to treat, or get all fancy about, how well cannabis works. but I'm really excited to hear about what patients' goals are and why they look to cannabis to help them. Very long list here. You can read through some of these. I might not mention them all, but we'll touch on some. So they found cannabis to help with function, analgesic in general, sleep, mood, appetite, energy, anhedonia, anxiety, concentration, hypnotic, reduce the use on the right-hand side, reduce the use of benzos, hypnotics, other substances, anti-inflammatories, legal substances. So in this study, there was actually reports that people were able to wean down on their alcohol and tobacco use, which I found very interesting. They use it to help reduce other side effects and withdrawal, burden of other conditions, disease burden, and to use it as a breakthrough modality. So the summary of the case that I just mentioned, so multiple medication failures were reported. Obviously, this was a case of polypharmacy where many medications were being used. She had reported many adverse events to those medications, not all of them, of course. And she has very, complex symptoms and complex pain. And so what I mean by complex pain here is that she's got multiple pain generators. So she's got evidence of neuropathic pain, and that would be the fibromyalgia, osteoarthritis, sometimes osteoarthritis, and degenerative disc disease. Nociceptive pain, rheumatoid arthritis, osteoarthritis, inflammatory pain. I think she actually had lupus. SLE stands for lupus, and I might have missed that on the first slide. Rheumatoid arthritis and mechanical, so wear and tear condition. So when you're dealing with this many types of pain, most pain medicines work on one particular pathway. An anti-inflammatory works on inflammation. A nerve block works on the nerve root that might be impinged. So you can see here, we're looking for something that can help as a multimodal approach. So opioids and cannabis, we actually have evidence that I'll share with you to explain how cannabis plus opioids can actually be better together than opioids on their own, and to be able to spare us from the side effects of opioids. I remember she showed up at the wrong office one time, and it was because she was kind of over medicated with either the opioids or the nabilone or a combination. So anything we can do to reduce the dose of multiple medications, can be very helpful versus going high with just one medication. So her plan in this case, due to the confusion she was experiencing, we actually stopped the nabilone and we put her on some daytime oil, CBD oil. She was driving a car and she was still working part-time. And so inhaled THC, that should say PRN, so as needed, and not pen. There are vape pens, but THC as needed. The reason being is when she inhales THC, she could do it around the activity she needed to do during the daytime. So for example, if she needed to go pick up her children, she would go pick them up and then she could inhale it before when she came back, or she could inhale it with enough hours before going to pick up her kids. Whereas an oil lasts for a lot longer, it wasn't ideal for her to use THC during the daytime. And because of her issues staying asleep at night, I didn't think it was warranted to give her something quick acting, which would be inhaled THC, but more, again, the THC oil to stay asleep. So you can see THC inhaled for the daytime, which is a different approach than THC oil for nighttime. And this is a poster that I presented a number of years ago at a conference. And it's a poster of 10 patients. I just want to, remind everybody of that. This is not, hard and fast. So this is a case series, if you will, of what patients reported to me that I followed pretty extensively who were using cannabis. So what you can see is not every patient had every symptom. 10 out of 10 had sleep problems, 10 people had sleep disturbances and anxiety and pain. And of all of them had improvements they reported. Not all of them had nausea, but of those that did, all of them had improvement in nausea, and the same for spasms. So what I'm trying to illustrate here is, because as you'll see, the mechanism of how THC and CBD work, it can be unique in helping to treat multiple different symptoms at the same time versus needing one medicine for nausea, one medicine for spasms, one medicine for sleep. You can start to see you're adding more medicines and adding a greater risk of side effects. And it might be appropriate to start that way, and then it may be appropriate to refine it depending on how well tolerated those medications are. And they had a variety of different types of pain, as you can see on this slide. Some of them had pelvic pain, some of them had migraines, some were headaches, IBS, and fibro. So let's just touch again on the endocannabinoid system. This slide you'll remember from last time. So THC and CBD are the main players that we're talking about today. You can see there's an overlap in their function, so they can both be helpful. In the green zone on the screen, we can see for pain, depression, anxiety, and nausea. And you can see under each of their own respective sides, CBD is likely better for inflammation, to neuroprotective. So maybe having use for depression, for dementia, Parkinson's potentially, traumatic brain injury, anticonvulsant activity. As an antipsychotic, there might be some studies. I've got some references on each of these statements here. So if anybody wanted the extra reading, I could pass that along. And THC on the left, we can see that they can be helpful for spasms, for appetite, and for sleep. But we also need to be mindful that they could cause impairment, and they are psychoactive. So just to be mindful of that, the risk, therefore is it could cause psychosis or something extreme if we're not using a safe low dose. This might also be familiar to the audience. I might have had a slightly different version of this diagram, but it's important to see that the cannabinoid receptors are diffusely present in the body. So predominantly CB1 receptors are in the central nervous system. You can see that they're more than that. They're in the brains, the lungs, muscles, GI tract, vascular, and reproductive. CB2 is more in the inflammatory and immune system, so the bones, the spleen, and the skin. And then there's overlap for sure in both of those other areas. On the right-hand side, you'll see the areas of the brain in particular where we can find the densities of the CB1 receptor in many different areas. So for example, number 7 is the amygdala. So looking at that, for example, fight or flight and trauma, and I'm sure many of us have done some reading on those areas. You could start to see where it might have a role in PTSD, for example. Number 3, the basal ganglia, that's important for Parkinson's disease and having smooth movements. And so potentially this could help those patients. So each day there's kind of more and more studies being circulated, and I really can't keep up on it these days. But I'm sure you can guess based on the different areas. Maybe cannabis could work for. I've recently seen some stuff on fatty liver and diabetes and glucose management. I'm not saying cannabis treats those things, but potentially it can modify or augment these systems. And so it's just something worth being aware of. And I'm sure over the next 10 years, we're going to learn more and more. So this diagram is a little bit complicated. I'm going to keep it pretty high level because I don't want to get bogged down, but just so you have a broad sense of what's happening at the molecular level. Let's call this a serotonin neuron. This could equally be it could be acetylcholine, it could be dopamine, it could be so many GABA, it could be so many other receptors, but let's just, for this, I'm just making it up, let's call this serotonin. And so a similar type of neuron secreting what's called a neurotransmitter through neurotransmitter vesicles will be found in all of the neurons, but we're just, talking about serotonin right here, for example. So the CB1 receptor, you can see that on your screen. I don't know if my mouse is going to show, but it's right here. CB1 receptor is at the presynaptic terminal. So it's over here on this side. Okay, somebody's letting me know that they can see my mouse. Thank you. So CB1 receptors here. And so we're seeing here the CB1 is going to modulate pain by acting as a circuit breaker to dampen the neuron depolarization. So what that means is over here, the postsynaptic terminal, this is where we're secreting different types of neurotransmitters. And these are going to have an impact over here. And so as you will see, let me move along in the steps. So the first step here is that we're actually going to make, number 1, synthesis in our body of endocannabinoids. So we are going to make our own anandamide, which is a natural form of, let's call it THC. It's like our natural THC, and 2-AG. we're going to make this on demand every day in many different pathways. We're going to make this even if we don't have pain. And you'll see that we're making it right here in this postsynaptic terminal, and it's starting to cross over here to the presynaptic terminal. The second thing that's going to happen once it's crossed is we're going to see that both the endocannabinoids and the phytocannabinoids, so if you were taking the plant, so THC, are going to be binding to the CB1 receptor. So that's over here, number 2. So these little hexagons are binding here, and also THC, let's say, is also working here. And then we're going to get activation. Oh, my mouse is kind of playing tricks on me. So we're going to get activation of the signaling cascade. So it's going to have a bunch of different steps that we're not even going to talk about, and I probably can't even tell you all of them. And most of us don't even understand what's actually happening. The body's just too complicated. But we're going to make these neurotransmitters, and they're going to actually cross the presynaptic, from the presynaptic to the postsynaptic terminal. My mouse is, oh, here we go. So they're actually going to be made here. They're going to abut here, and then a vesicle is going to be made. The vesicle is how they're going to be released, and then they're going to actually go this direction onto the postsynaptic terminal. So I think I apologize in the beginning. I said things were going this way, but the neurotransmitters are actually going this way. I made a mistake there. And then the last step here is we're going to get modulation of the neurotransmitter release from the presynaptic neuron. So what that means is, depending on how much of these neurotransmitters are crossing this pathway, that's going to have an impact on the postsynaptic terminal. And so you can start to see how we can put a brake on this system, or we can turn it up depending on how we are modifying these receptors. So this is at the molecular level, and I know it's kind of complicated, so let's move on. So what will patients actually tell me in clinic in terms of what they notice that cannabis can help them with? And they may say that the pain intensity that they experience can decrease by what we would say is about a 3-point drop on the VAS, the visual analog scale of pain. So that's saying they were at a 6 out of 10 pain, now they're at a 3 out of 10, or they were at a 10 and now they're at a 7. So it's consistent that on average, that's about the reduction that we get, that is reported. And this is shown in studies. Sorry, my numbering, I'm just noticing it says number 1 twice. Patients will also say that pain is present, but it doesn't seem to bother them as much. So it's the unpleasantness that's reduced. I just don't mind it as much, and I can ignore it easier. And so people might say, oh, that's because you're stoned. And, you know, it's possible if somebody was stoned that they could have that experience. But there's also a sweet spot that I've noticed that we can achieve where they don't have to be stoned and they can still experience this reduction in pain and unpleasantness. And that is the art of cannabis medicine, is finding that sweet spot without overshooting, because we don't want people to be stoned. We want them to have a reduction in that unpleasantness without being, you know, out of it completely. And so in more technical terms, at the bottom, you can see here, so the endocannabinoid system can influence the emotional aspects of pain sensation through the action on the frontal limbic circuits. And a recent fMRI study has actually confirmed that cannabinoids' ability to cause pain dissociation by causing reduced activity in this area of the brain called the ACC, or the anterior cingulate cortex. And this enhances the activity in the amygdala, which I just alluded to earlier. And there is definitely a tie between pain, anxiety, trauma. There's lots of connections that I'm sure many of you in this group have, you know, read about, or you had different talks about. So it's how can we dissociate from the pain without being dissociated? Like, we don't want to be, you know, totally shut down. And so a lot of neuroplasticity, rewiring the brain, Joe Dispenza, I'm sure you've heard a lot about this. There's many courses. I think Dr. Arsenault might have mentioned some of these, or Dr. Brenda Lau, who I used to work with as well. Annie Hopper, I think, has dynamic limbic retraining system. There's also the Gupta. There's many other ones, and I'm sure you've heard of some of these. So cannabis may be able to augment or help people who are maybe a bit more stuck in these neural pathways, let's say. No judgment on the stuck. I'm stuck many times in my own ways. All of us are. So where is cannabis actually working? So if we look here, this is a busy diagram, but I love it. I made heavy modifications because I looked really hard and fast, or well, not hard and fast. I looked for a very long time and actually couldn't find a diagram that did it as nicely as this one. And so I've added a lot of my own 2 cents here. So basically, I've broken down the medications in order of mechanisms or pathways. So you can see I've got calcium channel, I've got sodium channel here, NMDA, noradrenaline or serotonin, which is also called 5-HT. There's different subtypes, of course. And then in the top left, I've got a box called the endocannabinoid tone with a question mark there. And I'm going to mention about this on the next slide. And in that same box, I've also mentioned glial cell health. And glial cell health can be influenced by low-dose naltrexone, by PEA, which I'm sure Dr. Arsenault has talked about before. So that's actually interesting because it's working in a similar mechanism in which cannabis may also be overlapping on. And what you can see in this diagram is cannabis may be helping here in the endocannabinoid tone, in glial cell health, in sodium channels, and I've mentioned some of the mechanisms here via primary afferent non-neuronal. And it can also potentially help noradrenaline and serotonin through these different mechanisms, maybe calcium, as well as NMDA. So I think it's suffice to say, cannabis can help in central sensitization, as well as peripheral sensitization and descending inhibitory pathways. So that might give us a little bit more to chew on because, you know, how do you compare it with all of these other medications that people use for chronic pain? So this study is so fascinating to me, and it's not really a study, I should say. It's more Ethan Russo's a dear friend and mentor of mine, world expert, 20 plus years in the field. He's based out of a little island near Seattle. He's American. And so this was his research, well, not his research, he summarized research supporting these different areas. So he talks about migraines, fibromyalgia, irritable bowel, and other treatment-resistant syndromes. So in this summary, let's say this research summary, there's a few broad statements or themes that he mentioned that I'd like to share with this audience. So he talks about different pain states have been postulated to arise in part from a dysregulation of potentially the endocannabinoid system. So as you might know, we don't fully understand a number of different complex conditions. Like, what is the exact mechanism? Is it sodium channels? Is it calcium? Or is it the endocannabinoid system? So they use this word, he describes the tone. And so in particular, I found it fascinating that migraine patients actually had statistically significant differences in their central nervous system, the CSF fluid, anandamide level. So as I mentioned earlier, anandamide is that natural THC, if you will. And so patients with migraines actually have a different level than people without migraines. And so that's really, really interesting, I find. They also talked about PTSD patients. And on MRI, they actually showed areas where there was an hypoperfusion, means a lower amount of, hypofunction is a lower activity in these areas of the endocannabinoid system. So that might, lead us to believe, like, could there be something in the endocannabinoid system that isn't working as well in some of these patient populations? And so I just wanted to mention those two, as well as I have a little note to myself here to tell you a little story about a case report that I read on a post-operative case. I think she was a 70-year-old lady, and she had a really painful wrist surgery. And so anesthesia was quite confused that after this really painful surgery, I don't know what exactly it was, if it was plastic surgery, but that she required very little pain medication at all. I don't even think she needed any, or like the smallest dose. She just had some in the OR and then she didn't need it. And everybody else kept coming to the bedside, like all the different specialties were trying to figure out, she was ready to go home almost. And so they actually did serial blood draws on this patient. And what they found out was she had a really high level of anandamide. So she, like, naturally, it was like she was taking like a really good dose of pain medication. And so when they did further questioning, they said, well, have you ever had any children? And she said that she had two. And they said, well, how did the deliveries go? And she said, oh, they were easy. No pain at all. I just like popped them out or something like that. And then they said, have you ever broken any bones? And she said, oh yeah, I broke a few, like no problem. She had some burns. And so, I mean, some of us in medicine will have heard of this, that people can have different types of genetic mutations where they don't feel pain, and for different reasons. So this woman actually, they actually demonstrated that she had a high level of natural anandamide versus these migraine patients in this paper had a lower level, significantly lower levels of anandamide in their CSF. So I think that that's really interesting. So let's move on to talk a bit more about central sensitivity syndrome. And you're going to see me hop back and forth between different types of conditions here because there's no perfect study on just CSS, unfortunately. So I wanted to remind the audience about neuropathic pain. It's obviously quite prevalent. It's 20% of the adult population, which is 1 out of 5. This algorithm, if you haven't already seen it, it was created many moons ago in 2014. I've been hoping for an update. I don't know why it hasn't been updated in over, well, it's almost 10 years. It's 10 years now. I wonder if it's because, will opioids be removed from this diagram? Will they take them out of the management of chronic pain? I don't know if there's political, issues going on in the background, but I think what we're going to start to see is that cannabinoids, which you can see in this diagram, are a third line agent. So cannabinoids include nabilone, Sativex, which is a prescription form of THC and CBD, and the plant are cannabinoids, and they're right now as a third line, and they're going to start moving up the ladder. And I'm sure many of you know gabapentinoids, tricyclic antidepressants, and serotonin reuptake inhibitors, SNRIs. That's the venlafaxine I mentioned earlier, as well as duloxetine. There's a number of other medications. So those are all, let's call them first line agents, this first row. And then second line agents is tramadol and opioids. Third line are cannabinoids. And fourth line are things like ketamine, lidocaine, and other interventions, more invasive, let's say. But you're supposed to start at the top and then work your way down. And I think that the evidence is now very loud and clear that opioids do have side effects, and we might want to be careful in using them. And my hope is that, cannabis is something that we go to before we go to opioids in the future. I'm not sure how long that's going to take, but it's important to note that the evidence has been changing. And on the right-hand side, we can see the numbers needed to treat. And so these are fancy calculations, but you can see that cannabinoids is 3.4 according to the study. Again, there's always limitations with studies, so it's not a perfect study, but 3.4 means that it was better than, or it needed fewer people to be treated to get a response when compared to pregabalin, which is Lyrica, or gabapentin at 6.5 and 4.5. Tricyclics might have been slightly superior according to this paper. So I just wanted to put this in perspective of where cannabis is when we compare it to other medications that many of you may be taking. So this one here, ingestion of THC cannabis oil in people with fibromyalgia. This is a randomized double-blind placebo-controlled trial, which is kind of the gold standard, if you will, when it comes to studies. And so here you can see there were, oh, I'm sorry, I thought I put the number of patients here. I'm not seeing the number of patients. But basically these patients, it was 8 weeks long, so it was 2 months, which is a pretty common standard length for chronic pain. Unfortunately, it's always nicer to have more data, but that is common. So they use 1.22 milligrams of THC and 0.02 milligrams of CBD per day. And they went up to the doses indicated here. So very low CBD, higher THC. And the results here, low-dose cannabis group presented a reduction in pain, fatigue, anxiety, depression, and improved physical function and ability to complete work. And, there's side effects, and this needs to be weighed against other considerations, as always. Another study on medical cannabis and fibromyalgia. Here you can see the mean dose of medical cannabis was less than 1 gram a day. So these are very low doses. These people would not be stoned at these doses. And the same with the previous page. These are low doses. And this was an Israeli group of patient population. There was 26 patients. So these are small studies. So we need to remember that. And all the patients reported a significant improvement in every parameter on the questionnaire. 13 patients, 50% were able to stop taking any other medication for fibromyalgia. And 8 patients, so 30%, experienced very mild side effects. And I can't exactly remember what the mild side effects are, but they sometimes are a bit of dizziness is a common one that patients might report. And a lot of times those side effects go away over time. It's just as you're titrating up to the desired dose that you might experience them, because there is a phenomena of tolerance that's experienced. So the conclusion from the study is that medical cannabis treatment had a significant favorable effect on patients with fibromyalgia with few adverse events. Then you can read another paper, I'm sure you can find one, that says it had no favorable effect and they had all these side effects. And so I just find it frustrating because it really depends on what they're looking at, and numbers and statistics are tricky things. And sometimes what I found when I read the appendices and, and I know this literature, is that they'll exclude all these patients for various reasons who actually responded, but for whatever reason they exclude them, and then it makes it look like nobody responded when that's not necessarily true. So evidence is good, and physicians like to hang their hats on things and like to have reasons for doing what they're doing and to make sure they're acting in the best interest of the patient, but also to realize that with patients such as central sensitivity syndrome, complex diseases, when patients have tried other options and they're not working, it's appropriate to try something that might work and to monitor, be cautious, start low, go slow with treatments such as medical cannabis, because it might actually be what is the most helpful for them. So we need to be open-minded. This one here is inhaled cannabis. So previously we were talking about oils, which you swallow and they act for 4 to 6 hours. Inhaled works within 5 minutes and lasts for a couple of hours, so much more short acting. So in particular here, they've reported, I wanted to highlight on this slide, that inhaled cannabis is similar to gabapentin in terms of its potency, or if it's, how well it worked. And so as I mentioned on that diagram, start with gabapentin and then move your way up. We're actually seeing more literature speaking about side effects of gabapentin, and maybe it isn't as great as we once thought it was. And I'm not sure if anybody's shared, I'm trying to remember the name of the study. It was a European group, and it was fibromyalgia guidelines, I think, that came out of Europe, stating that they were removing gabapentinoids from the treatment for fibromyalgia. And it was because they had noticed there was a lot of side effects. Now, that doesn't mean don't use gabapentin in fibromyalgia, because it does work. For some people, again, there's always that caveat, but enough to say that we need to put the same level of scrutiny on all medications, whether or not they're prescription or they're a plant like cannabis. We need to be careful. And so you can see here that the study showed a 30%, greater than 30% reduction in the pain scores, which is, again, that 3 out of 10 drop on the VAS scale that I mentioned earlier. And this was a little bit of a longer study. It was 3 months. And this was across North America, and quite a few more participants in this study. Here we're talking about nabilone. So nabilone is that synthetic form of THC. There's no synthetic form of CBD you can buy, just of THC. Nabilone can be good in some ways because it's covered under drug plans for people that have limited income. But I have seen in some patients it lasts a lot longer than THC. And so as a result, we need to be careful, because if you're having a side effect, it could last a little bit longer. So my recommendation is, if anybody ever wants to try nabilone, to start with the absolute lowest dose possible, which is 0.25. So most physicians don't even know. My mentor of many, many years, psychiatrist, pain doctor, VGH, super smart guy. I've learned so much from him, as well as Dr. Arsenault. He didn't even know that nabilone came in 0.25 until I mentioned it to him. And the reason is that the studies are done in a certain strength. They may be done in the 1 milligram most commonly. And quite frankly, 1 milligram is just a nice number. So people say, oh, let's start it on 1 milligram. Well, 1 milligram is 10 times 5 to 10 times the starting dose of what I would start a patient on who's sensitive, such as somebody with central sensitivity syndrome. So don't say, oh, that drug doesn't work. It's important to say, how do I, get the lowest dose or compound nabilone? There's different ways of approaching it. And I know Dr. Arsenault is really good at compounding low dose naltrexone and all kinds of fancy protocols that we can do for people who are sensitive. So here in the study, nabilone 0.5 to 1 milligram, which again is a much higher dose than I would use. And amitriptyline was the other dose that was being used. And here it said that nabilone was superior to amitriptyline. And you can see there were side effects, dizziness, nausea, dry mouth, and more was seen with nabilone. And guess what? That's probably because the dose was a bit too high. I think you would probably get the same outcomes with half of the dose that they did. But yeah, I don't know where they get their dosing from. In some of these studies, it just would be so nice to be a little, fly on the wall and figure that out. But anyways, just enough to say that it's on point again with amitriptyline. We've just heard that's a tricyclic. It's on point potentially with gabapentin. So we're starting to see that first slide I showed on the chronic pain, Canadian Pain Society chronic pain guidelines. I think we're going to start to see cannabis is moving up to that, fingers crossed, maybe first or second line for sure. And again, this was a small size of only 30 patients. This here is 10 years old, this data, but it's always just nice for comparison to see numbers because I'm sure it's not too far off that. Mind you, maybe more people are using cannabis, so it could be even more favorable towards cannabis. In the US, I find they always call it marijuana. So that's what I put there, even though my preferred term is cannabis. Marijuana for me is a slang term and it has different connotations and stigma, and it can have racial stigma as well. So I don't like to use that word. It's like people saying narcotics versus opioids. Narcotics just doesn't have the same medicalization, let's say. So just wanted to say that it's a little bit of a pet peeve of mine. So here you'll see FDA-approved medications for fibro. I need to clarify that cannabis is not an FDA-approved medication, but the top 3 are. And if you look across the top, very effective, helps a little, doesn't help at all. So when we look at cannabis, 62% found it to be very effective in fibromyalgia, while only 5% said it doesn't help at all. And if you look at something like Cymbalta or duloxetine, 8% said it was very effective, while 60% said it didn't help. So it's very interesting. It's almost the complete mirror opposite. 8 is almost 5, and 60 and 62 are pretty close. And really, pregabalin is very similar as well, maybe a little more effective than Cymbalta, let's just say. But anyways, I think you get the gist of this here, that I always like to look within a patient population. So fibromyalgia is such a heterogeneous condition. What that means is it presents very differently. There's really no two patients with fibromyalgia that are identical. They can have very different symptoms. And so I think because there can be so many different symptoms, that's why cannabis can be unique. And so I like to compare, apples to apples. This is as best as I can do here. Let's talk a little bit about cannabis and opioids. So cannabis opioid mutual potentiation. I'm just checking my clock here. I've got about 20 minutes before Q&A, so I'll keep that in mind. So basically here, how is it that cannabis and opioids can work together? And what we've learned through scientific kind of laboratory animal studies is that these receptors are actually co-localized in the nervous system regions responsible for pain modulation and processing. What that means is the cannabinoid receptors and opioid receptors are close together. And so we think that they share signal transduction molecules and pathways. And so what that might mean is THC can increase the endogenous, so that's our natural production, our endogenous production of opioid release and upregulate opioid precursor genes. So that means that THC might make opioids more effective, is basically what I'm saying here. And this is reference, this is not just me. And I've observed this time and time again. I can't even tell you the number of patients that start on cannabis and they're on an opioid, and I say, don't do a cold turkey taper. We want to come down slowly. You've tried to come off an opioid in the past and you've had withdrawal and it's been really hard, and we're not in any rush. We can take our time. And when I see them in follow up, the opioids are completely gone. And I said, what did you do? Like, what happened? We said we were going to talk about this. And they just said, I didn't eat them. Like, I just realized that they were almost working too well. And at times they might have felt a little more sedated. So what they decided to do instead was to reduce the dose on their own. And they felt that they knew how to do that. This is an interesting study here. It is this was an Israeli, I'm pretty sure this one was based in Israel. Yes, it is. I met Silvio, the second author. I met him at a cannabis conference. He's a chronic pain expert in Israel. And so this was his patient population. Very interesting study here. This is in depression and anxiety, which is experienced by chronic pain patients because he's a pain physician, and they were receiving opioids and medical cannabis. So it's always interesting to see and tease out, does depression and anxiety come from the chronic pain, which we do know that there is an association, and can depression and anxiety come from opioids? And there has been some suggestion in the evidence that this is true. So the question is, oh, well, if opioids help the pain, then that should make the depression and anxiety better. But sometimes we see that opioids actually make the depression and anxiety worse. So here, what you'll see, I've highlighted in red, a circle around the last column. Let me walk you through what you're seeing here. So this is a total of about 900 patients in Israel. They both had, you can see the percentages of depression and anxiety, pretty similar profile. So almost 500 were treated with opioids only. And opioids are represented in this diagram in the dark gray. Let's call it the slate gray. That's the opioids only. And then about 330 patients had cannabis only, which they call medical marijuana, which is MM, and that's the light gray. And then about 77, so about 80 received opioids and cannabis, right? The two of them together. And that's the beigey color, tan color there. And so I would have thought that cannabis and opioids together would be better. And what you can see is it isn't true. In this study, that the patients that had the lowest amount of depression and anxiety were those that were only using cannabis. So for depression, about 20% in those using cannabis, 20% had depression, and about 30% had anxiety in those only using cannabis. And in using opioids, about 60%, almost 60% had depression, and about 50% had anxiety. So much higher. And then in between, it actually, cannabis with opioids, they were pretty much the same or very close to that of just using opioids. So yeah, there's something interesting there. And, I think we've talked about earlier that it works in so many different ways, in so many different pathways. So I'm not totally surprised, but initially I thought it was very interesting. And then when I thought about it, it made sense to me. Here, this is a study by Dr. Zach Walsh and Philippe Lucas. I think he's got his PhD now, so he may be Dr. Lucas as well. Zach is based out of UBC campus in Kelowna, and Philippe is over on Vancouver Island. And they were doing a survey, this was many years ago now, but they were some of the first to do work in cannabis access, use, and substitution, and describing how patients use cannabis. And you can see here, opioids, these are not great colors that have been chosen because they look similar on your screen. Like, why use 3 color blues? Why not use purple, yellow, red? I don't know. But anyways, I don't know why people choose the diagrams they do. So here you can see that a lot of people substituted opioids with cannabis. Also, a lot of them substituted benzos, not as many for benzos, but still benzodiazepine, that would be your Ativan, clonazepam, diazepam, Valium, and so forth. And antidepressants, probably anti-anxieties, because those are also similar to antidepressants, and other medication. So other medication could be gabapentin, it could be pregabalin, it could be muscle relaxants, we don't know. And they divided them here by all patients in the first column, or the first set of columns, and then pain patients specifically and mental health patients they separated those ones out. So this group that I'm speaking to this evening are pretty much, I would imagine, mostly pain patients. So we can see here that about 40% of patients using cannabis were using it to substitute for opioids. But also 35+% were using it for other medication substitutions. Those were definitely the highest. And then in mental health, it was pretty much across the board similar. But yeah, I thought that was interesting. And also they reported in this paper, which I put in the margins here on the right-hand side, that most patients were actually able to reduce their opioids by 50 to 75%. And so I wonder if they're able to reduce them, if the relief is coming, yes, from cannabis, but it's also coming from probably the side effects the opioids were having on anxiety and depression and other things. And 25% actually came off opioids completely. So talking a little bit about the harms, especially of high-dose opioids. So there's only modest evidence for opioids in chronic non-cancer pain. And I would say, I made this slide a while ago, but I don't even know how modest that evidence is. We talk about chronic non-cancer pain versus chronic cancer versus cancer pain, because cancer pain is a different kind of pain. So this audience, chronic non-cancer pain is chronic pain. Let's just use those interchangeably. And so we've seen with high doses, the benefits become offset with the increasing risk of serious adverse events. And we know all too well, living in Vancouver for the majority of us, that overdose and death is the most concerning issue using opioids. But there's other side effects using opioids, adverse events, including constipation can be really bad, probably one of the number one complaints. If patients are on opioids, it's really important to be on laxatives such as PEG or Senokot, for example, or Sena. Nausea is also common with opioids, vomiting, sedation, dependence, addiction, physiological tolerance, needing higher and higher doses, and then the risk of unintentional and possibly fatal overdoses I've alluded to. We actually know that when you're on more than 50 milligrams of morphine equivalents, so there's ways of converting if you're on hydromorphone or oxycodone to morphine. Morphine is our standard unit that we use when it comes to opioids. So if you're on the equivalent of more than 50 of morphine, it actually doubles the risk of a fatal overdose. And then if you're on 20 morphine, this is compared to 20 morphine MMEs. But if you're on greater than 90, it actually increases the risk by tenfold. So I think that that's really, really, significant distress. And I think I said that a little bit wrong. Let me rephrase that. So when you compare 50 milligrams to 20 milligrams, you're doubling, which makes sense because 50 is doubled 20. And then when you're up to 90, it's a tenfold risk. So it is actually not even just double, like it is exponential. So with that in mind, I had a couple of really keen students and colleagues that we wanted to put something together to help give advice to patients who were using opioids and wanting to use cannabis. And so we created a tool for basically the safe initiation, titration, and monitoring for cannabis therapy. And we were targeting at chronic pain for chronic pain patients, or patients with chronic pain, rather. Sometimes I say that the wrong way. And so this is not people with cancer. And these patients in particular were not reaching treatment. They were not reaching the desired pain management goals that they were wanting. And they were receiving chronic high doses of morphine equivalents. I know this is a very busy slide. This is taken from the paper and it's available on my website and in the papers in different ways. So I'll just walk you through it a little bit. But basically, step one is identifying the right patient and seeing who might be somebody, a candidate to initiate cannabis to see if we can reduce their amount of opioids or at least prevent escalation of their opioids. And, we do this by checking their brief pain inventory, checking to see what their history is for anything that might make cannabis not a good choice. And then the next step two, starting cannabis. So daytime starting with CBD, evening starting with THC, sometimes going a little bit lower depending on their sensitivities, and then increasing the CBD and THC, as you can see in these in the boxes there. by 5 to 10 milligrams of CBD every couple of days, and increasing THC by 1 or 2 milligrams every few days. And, checking in, testing and retesting how they're doing, because we don't want to tip over to where they're getting too many side effects from cannabis. We want to find a sweet spot. And then monitoring, of course, as I mentioned, to make sure that those goals are being achieved and that side effects are being managed. And then optimizing the titration and, oh, just sorry. Is that okay? I just need to finish my lecture in here. Okay, just lay it down quickly. Thank you. Sorry about that. Sorry, that was one of the nurses there. So frequent monitoring of opioids and seeing if we actually need to start dropping the opioids as we're monitoring for the cannabis initiation. And then you can see some people might not respond to cannabis. They may actually not be a good patient prototype, and that's okay. And then reevaluating. Sometimes we need to add vaporized cannabis on. Sometimes we need to add on an oil. It depends, patient preferences and the type of pain. And then again, we might stop cannabis if that is appropriate, and certainly reassess opioids. So I can see I've got 10 more minutes left. And with that 10 minutes, I actually had 2 more cases that I'd like to squeeze in there if we can, because I think the audience will appreciate them. They're slightly different versions of the first, but they illustrate different points. So I'm going to try my best to get through them. So this second case is another patient with fibromyalgia for 10 years, and she was 67 years old, and she had diffuse like pain. Some people with fibro that I've seen, it might be in certain extremities, and then some, of course, have it pretty much all over. And allodynia, so really, really, really sensitive to touch and to even the wind or the air breezing over different areas of the body. So very sensitive. Past medical history had moderate bilateral, as BL, bilateral knee osteoarthritis, and also had a lot of stress. Her son was very unwell. She was taking oxycodone as needed, gabapentin, and venlafaxine or Effexor. And the issues she was working with was daytime pain and falling asleep. So this is different than the first case where she didn't have issues falling asleep. She had trouble staying asleep, but also had daytime pain. So I'm going to ask you to, in your mind, I guess, give this some thought. The fibromyalgia, which we believe has some inflammatory underlining etiology. It also can have a chronic nerve component to it as well, and be classified as chronic pain because it's persisting for greater than 6 weeks by definition. So for the daytime pain, what might we want to use? Something perhaps like CBD. I said it wrong. The CBD is good for inflammation. We've talked about that a few times. And the oil, because we're going to get a longer duration of action. I very infrequently use inhaled CBD. If somebody's needing inhaled, they need it because they want it to work quickly. And usually they want, I'm just almost finished here. They want it to work quickly. So inhaled would be to fall asleep. The THC would be very helpful. And staying asleep would be the oil. So in the first case, it was oil to stay asleep. And here we're seeing inhaled THC to fall asleep. So slightly different. I wanted to highlight that plan because some people in the audience might have the same issue. Maybe falling asleep is challenging because their mind is racing, or they're anxious. Oh, tonight's going to be another difficult night of sleep. I know sometimes I feel that way when I haven't slept a number of nights. I'm like, oh no, it's going to be another bad night. And then those thoughts kind of self-fulfilling prophecy, like that's going to beget that whole outcome. And so some people, they might just need, using inhalation. It may be that we're treating the anxiety, to be honest, more than we're actually treating sleep. And then when we manage the anxiety, then they can fall asleep. And then for others, they can fall asleep because our first patient was taking, as you might recall, nortriptyline and trazodone at bedtime. So didn't need it as much to fall asleep, but staying asleep was more the issue and was frequent waking because of pain. So everybody's different. This last case, we're going to talk about a 46-year-old. This one more complicated. chronic regional pain syndrome, CRPS, CRIPS, you might have heard different words used to describe this, central sensitivity syndrome, sciatica, neuropathic pain, has, again, that very sensitive skin, sensitive to touch, also has redness, swelling, sweating, which is seen in CRPS, also has photophobia coming from migraine, so eyes are very sensitive to light, also impaired balance, unsteady on their feet, fogginess, brain fog, and memory impairment, again, for many reasons. A lot of times medications can give memory issues, but also brain fog can certainly do that. And also PTSD, endometriosis, and some herniated discs. Medications, we talked about a number of these, but here we've got a couple new ones. Cyclobenzaprine, also called Flexeril as a muscle relaxant, low-dose naltrexone, LDN, and topiramate, Topamax, which has also been used for neuropathic pain. So the issues in this case, daytime pain, but trouble falling asleep and trouble staying asleep. So both problems this time. So I think you've probably caught on by this third case, what we're going to be recommending for, at least for the sleep. For the daytime, there's a number of ways to approach this. So for the daytime CBD oil, because we do believe there to be an element of inflammation. Also for daytime, inhaled THC as needed breakthrough for migraines. So what I actually observed in this patient was using CBD oil every day actually reduced the severity and the frequency of migraines. So there was something in the migraines that might have been inflammatory in nature, because we did see that they improved. And then for nighttime, needed inhaled THC to help fall asleep, to help with the racing thoughts, and then THC oil to help stay asleep. So I think that that's a nice case to kind of finish things off and tie this together. But there's many different protocols out there and regimens depending on somebody's needs. But I just wanted to highlight some of those. Also, just to mention a few things that I didn't get a chance to last time. On my website, safe-cannabis.com, there's a number of different information handouts that different students have made. Some of them are posters, some of them are brochures. Again, they're free for download and for use. They summarize, frequently each of them summarizes a paper that I've had that I've written with my team. And we do it this way because you can tell this is much easier to read. You know, for example, the bottom one here, step 1, 2, 3, 4, 5, instead of that busy diagram I was showing you in the last slide. And so, yeah, just different ways of representing information. I find myself, I have ADHD, and I find it really hard to read a lot of dense text. So when I write a paper, it's written for me. I'm selfishly writing it for myself. So if I ever have to go back and read it, I go straight to the diagrams. And so that's why you'll see that these should be easy to use. So please download those if you need to. I was involved in writing this book. I'm not recommending that you buy it because it's actually, I don't know if I would read it again, to be honest. It's very, very dense and it's very academically driven. But I just wanted to mention that I was part of this group. So there is good information that's getting out there. This one in particular is by Springer. I've also helped with an Elsevier book. And I'm in the process of writing a mini book series for patients. Again, they're going to be filled with infographics like the last slide I showed, and they're going to be no more than 100 pages. So definitely good for people who are distracted and or just want the quick and dirty, or brain fog. So that's I'm targeting wanting to make this for everyone essentially. And there's a handbook here, but this is for physicians in particular, and it was just left in my slide deck there. So with that, it is 59 minutes after the hour. So I am right on time today, which is so great. I'm just going to stop sharing my screen. And I can see the Q&A button. You can be taught. I have learned, Dr. Arsenault, how to do this. And now I can start answering some of these beautiful questions. So there's about 40 questions here. I'm going to do a better job this time of scanning them before reading them. The reason is because some of them were a bit redundant, and so I'm going to try to paraphrase them so we can get through more of them. And I realized after when I checked the timestamp on these questions, some of them were asked before I'd even started, and I'd answered some of them. So I'll just see what makes sense here. So this first question, so this is somebody with a family history of pulmonary fibrosis. So pulmonary fibrosis is a lung condition where the lungs scar and can become hardened. That's fibrosis. And so they're wondering about vaporization and if it's recommended or is it safe. So first of all, family history is a family history. It doesn't necessarily mean that you're going to have pulmonary fibrosis, but the point is well taken. We want to be cautious. I want to remind the audience, I think we got into it a little bit last time, but I can't remember how much time I had. Smoking cannabis is inhaling polyaromatic hydrocarbons, ammonia, tars, so many different molecules that actually cause a lot of inflammation in the lungs. And when you get inflammation, you can get scarring. So smoking cannabis, definitely wouldn't recommend that in somebody like this. However, vaporization is a vapor. So when you boil a kettle and there's a vapor steam that you see, that is a vapor. It's 100 degrees or hotter in a vaporizer. And these little, the trichomes on the cannabis plant release the CBD, THC, the cannabinoids into the vapor, and you're inhaling the vapor. So I have used vaporization in patients with lung disease, lung cancers, asthma. Some people can be more reactive. Their lungs can be really irritable and they might cough with inhaling anything, whether or not it's vapor or smoke. I mean, smoke I would never recommend. And sometimes I've been a bit sneaky and we've been able to get them a vaporizer that we can dial it down to a really low temperature where it's not as irritating. Because sometimes I've noticed when people get irritable when they inhale, it's because the setting is too hot. And the hotter the setting, the more of these molecules that we don't desire are being produced. It's probably getting closer to smoking and further from vaporization. So vaporizing is always tricky because sometimes they can call it a vaporizer and it's actually, it can be burning. So we want to be careful to keep it on a low temperature. The other thing I want to remind patients, this is a great segue, is as cannabis gets drier, so if it's older and drier, you need to turn up the temperature on the vaporizer to actually get it to vaporize. So instead of doing that, a trick you can do is put these packets of rehydration packets, the opposite of the ones that come in your pill bottles that dehydrate. You're going to actually rehydrate your cannabis, make it more moist, and then you're going to be able to use a lower temperature for vaporization. I've had patients put a piece of apple or a little bit of carrot in with their dried cannabis. And again, that can kind of help rehydrate it. You know, you wouldn't want to do that for too long. You might get some mold and other things in there. You need to be careful. But yeah, these are just some tricks. So I am not of the opinion that you can't vaporize. I think you could vaporize and be careful in doing so. So that's an excellent question. And that was a long answer, but it kind of got me on a couple of tangents that I wanted to address there. Somebody missed the first talk. What was the subject? So it was more a 101. Let's just say we talked about CBD, THC, flower, oils, the different routes of administration, the different conditions that cannabis can be used for, the side effects to look out for, how to start it, drug interactions, a lot. We talked about a lot and it was recorded and it's available. So I don't think we're going to do it necessarily live right away. I have been in discussion with Dr. Arsenault potentially about doing a series of different types of cannabis lectures because there's so many things to talk about. But it might be worth it actually to get a circulation and get a sense of how many people are interested and what topics people are interested in, because yeah, I just don't want to make a whole slide deck and realize that people aren't interested. So let's loop back on that. I've got it on my list to address. Here. Somebody here is looking to try THC for sleep. We've talked about that a couple of times this afternoon, but concerned about orthostatic intolerance. So orthostatic is blood pressure changes with sitting and standing or lying and standing. Some of you might have POT syndrome and may understand that as well from that. The question is, could CBD help counter that? So a couple questions in this question, so quickly try to address some of them. Number one is whenever you get up from lying down flat at nighttime, it's happened to me, you can get dizzy. So when your blood pressure is changing from position, you need to be careful. So if you're somebody who knows you're already sensitive to blood pressure changes, sit on the side of the bed for a minute, stand up, hold on to something if you need to before you start walking. I think it's really good to do that even if you're not taking any medications. Each medication you may add to the combination, if it works on the nervous system and on the brain, it potentially could cause a bit more unsteadiness or dizziness. So that is there for every medicine that works on the central nervous system. It would equally be there for gabapentin, for amitriptyline. We would use the same advice. THC, I have seen case reports of hypotension, which is a low blood pressure, in very high doses. I have not had a patient tell me, I can't take THC because it's dropped my blood pressure. Like it's not a blood pressure like significant agent for dropping it. And so with that, what I would say is when you start low and go slow, you're going to be much safer that way. I have had some Parkinson patients, one or two, their blood pressures at baseline are 70/50, very low. So I've even used THC in them, but I've started with CBD first because I just think it's safer. So the second part of the question was, does CBD counteract it? It's not necessarily that CBD counteracts it. It's that CBD frequently contains a lower amount of THC, and it's probably a better place to start if you're worried about this. I would agree with that statement. And as you increase your CBD, you're increasing the THC, which is in there in the background because there's no pure CBD only. And then you might get to a point where you can use straight THC, if you will. And again, start with 1 milligram, 2 milligrams, and go up from there. And this is why it's important to see a physician that does a lot of this. The clinic I work, Greenleaf Medical Clinic, we see a lot of patients and we're really good at this. We've seen over 80,000 patients in over 10 years. And we've got all these tricks that we can do. And the second part of the question was that the person was taking trazodone and trying to reduce the dose because they were experiencing orthostatic changes. And so, yeah, certain drugs can actually cause more of that. And you may be pleasantly surprised that CBD and THC might not even, have those same issues. Next question. They've tried different oils. They get annoyed with the oils. I'm not sure why they're annoyed. It might just be because you haven't really found the right combination. Like each oil comes from a different plant or combination of plants. And sometimes it is a little bit of trial and error. I have to say it's not, we're pretty good at matching this condition with this kind of flower because we've seen so many, but it doesn't always hold true. The second part of the question is, what about inhalation? I think inhalation for some people, especially if you've tried the oils, it could be a great option. I don't always recommend inhalation off the bat because, let's just talk about that a little bit. And this is what I talk about in my other advanced or other lecture series that I do, like how you vaporize. You have to grind up the flower. You need to dump out the flower. You need to put it inside the vaporizer. You have to be able to see the vaporizer, turn it on. And, there's some steps there. So it's not the first thing I would recommend. The oils usually are. But for somebody like this who's having a side effect with an oil or just annoyed and it's just cumbersome, a vaporization allows you to take an inhalation, wait 5 minutes, 10 minutes, take another inhalation, maybe take 2, wait 5 or 10 minutes, and then take another or take 3. So you can titrate and work yourself a bit more quickly with a vaporizer because it's more forgiving and because it takes longer to work. It takes a shorter period to work. And it's not like an oil, which you have to wait 2 hours to see, oh, was this too much? So vaporizers definitely have their place. So I just want to mention that even though you might think it's also annoying for different reasons, it could be helpful in this situation. Somebody's asking, could cannabis help for pain when the symptoms are flared and the cyclobenzaprine, so the Flexeril isn't working? So cyclobenzaprine is for muscle spasms. Cannabis, actually, some of the best evidence is surrounding muscle spasms. In particular, the studies have been done in multiple sclerosis, but muscle spasms, are kind of muscle spasms. They're usually quite similar in different types of patients. And so, yeah, I definitely think that THC is better than CBD for spasm. And then the question is how do I do this without getting high? So start low, go slow, which we talked about in the first presentation. But I didn't get specific into doses because there's so many of you on this talk, just to kind of say, oh, this and that. I would hate to misspeak and give a wrong, recommendation. I need to kind of see the whole scenario. Yeah, and saying it's hard to function if I'm not sleeping, and if I'm not sleeping, the pain is higher. So definitely, I very much appreciate that biopsychosocial impact. And so needing to get on top of a spasm and get on top of a sleep, vaporization can be a really, good tool for some people who don't want to take cannabis every day. So say you sleep okay some nights, or you don't want to use it all the time, you can't just take an oil today, wait 5 days, take an oil again. With the oils, you have to start at a dose, work your way up to your sweet spot, and then stay on that dose because you've gotten used to that dose of THC. But if you stopped it for a week and went back to that dose of THC that was working, you're going to probably overshoot and maybe be a bit impaired. So with oils, you need to take them every day if you're going to take it for sleep. But with a vaporizer, you can take THC tonight, wait a month, wait a day, you've got a lot more flexibility. So I think that that's a great question, that vaporizers, especially here, they're mentioning taking care of their child. You don't want something to last for too long. You want it to work quickly, but you might just want it to take the edge off and not be too intense. So certainly worth considering. Somebody here saying they previously had some addiction issues with cannabis. I'm just trying to read the rest of it. What was previously having difficulty with it? Yeah, so it really depends on what you were using, how much you were using. I think I've stressed that the dose is everything. And so unfortunately, with the dispensaries, people go and they buy a gummy package and it's one gummy. So they take the whole gummy because there's one gummy in the package, and that makes sense. And on the label, it says 1 unit, and it makes sense that you would think you would take the unit. I have patients that cut that one piece into 10 pieces because they only want 1 milligram, not 10. You can start to see why it's no wonder some people can get addiction problems, because they're not really set up and supported in the system. So I think the way we're describing the use, it's very medical in nature. That the only 2 times I've seen addiction with cannabis have really been with people who have come to me with addiction, not with the way we do things. We have not seen that. So I think it could be an option. Even if you had a history, we just need to be very open about that and have good check-ins. And yes, cannabis can cause a racing heart, tachycardia. It can cause that when you're on too high of a dose of THC. Again, that would be consistent with the addiction piece. And interesting, difficulty with high blood pressure with cannabis. And I've seen the opposite. The higher the dose of THC, I've seen a lower blood pressure. I haven't seen that. So I'm not sure, maybe it was agitation or irritability. It could have been, because if people are in pain and irritable, their blood pressure can be up. So that's kind of, I think, fair to say. Somebody here is saying CBG is the best for inflammation. So I haven't heard a lot about that, but that's really good for me to know. I've heard CBG in particular for anxiety to be very helpful. People have told me that. But thank you for that. I've also heard CBDA and THCA, so the acidic forms of the cannabis plant. So they have not been activated to CBD and THC. So the acidic forms, they can also be good for inflammation as well. You'll hear people talk about juicing the leaves of the cannabis plant, and that's why, because of the anti-inflammatory effect. Here, can this treatment help with POTS? And so we just talked about a little bit about blood pressure issues. So cannabis, THC namely, can cause a bit of, potentially at a higher dose, a drop of blood pressure. At a low dose, I haven't seen it do that. So we would definitely need to be careful with somebody with POTS. And I can't say that if you have POTS, I would say, let's try cannabis for the POTS. I would say, okay, do you have anything else with your POTS? Okay, do you have sleep problems, anxiety, depression? chronic fatigue, other things. If you do, let's try probably CBD first for those conditions. And let's see if those can get better. And then maybe by treating those other symptoms, you might find you're reducing the burden of symptoms, and therefore indirectly the POTS may feel more manageable. It's possible. But I haven't specifically used it for POTS. Is this session for patients or doctors? So yeah, this is meant to be for patients, but physicians are more than welcome to listen to the recording. When I talk to physicians, I might use different papers to illustrate points that are a bit more intense and number oriented, because doctors just like that. But I'm trying to make this a bit more relatable and practical, if you will. Would I recommend cannabis for sleep, in particularly waking and getting startled and like abruptly startled? And so sometimes when I hear startled and abrupt waking, I wonder about nightmares. I wonder about PTSD. Sometimes there can be a little bit of that in the background. And absolutely, THC more so has been used for PTSD than CBD with success. In particular, I've worked with a large veterans populations, and veterans in particular, military can have a lot of PTSD, RCMP, different first line responders, and THC they do find helpful. So yeah, I would be curious to know if sometimes if you're sleep, you're waking because of PTSD, it could help with both PTSD and sleeping. Another comment I'll make, because I can't help it, just being a pharmacist and a little bit of a medication geek, I guess, here. Prazosin is another medication. It's a blood pressure pill. It's an alpha blocker. It's not a good blood pressure pill, actually, but it's used off label for nightmares. I find that has been successful for people who have a lot of like abrupt startleness or frequent waking. I've actually used it in patients where they don't even report nightmares, but it might just because the nightmares aren't even there, but it's probably there, but maybe they're subconscious. So when I hear startled, I just want to mention that. Also, clonidine is another thing that can be another medication. It's a blood pressure agent, and it's also used for, sorry, I was a little distracted by that. It can also be used for nightmares as well, but I would say that prazosin is a bit more effective there. Cannabinoids work. How do they work with Ativan? So I don't love mixing different kinds of medications. I would encourage you, because Ativan is short acting, to try to use cannabis first. And then if you have to use your Ativan, to use the Ativan as a breakthrough. But I wouldn't necessarily want to use the two together if I didn't have to, just because Ativan can make you a bit drowsy, THC can make you a bit drowsy. It could be additive and not necessarily beneficial. So yeah, I would try to start that. But usually I try to add cannabis to a stable medication regimen before I would take away from any medicines. But with Ativan, I might try to skip that dose until it's determined that it would be needed. Somebody's saying they're confused and a bit overwhelmed with this content. So I apologize. I'm trying to cover so much content in such a short period of time. And certainly I do want this to be accessible. So I would love feedback, and I don't know what the best way to go about that is. So if it's best to email Dr. Arsenault and specifically say, if there's different topics that would be, I could break them down. Like maybe we just covered a lot in one period. And I did it because I only had 2 sessions that we were doing. So I wanted to make sure I covered a lot. But definitely, like when I've got, multiple hours of time to explain things, I can go at your pace. And when I can see faces, it's so much more different than talking to a black screen here and not knowing if I've lost any of you. So apologies for that. Yeah, and this is a lot, especially if it's the first time you're hearing it. And so I would recommend listening to this recording again. And I would recommend pacing and even breaking down, just listening to 5 or 10 minutes of what we've talked about at a time. That can be another great tool because it is going to be available. Somebody's wondering about what they would do next if they're interested in cannabis. And so, yeah, you can get a referral from Dr. Arsenault if you want to come see us in clinic. They're asking about clinic. And at that point, we could help with dosing. The intention of today wasn't to like give you a care plan and to tell you exactly how to do it. It was just to illustrate, different kinds of cases and patient profiles that might be similar to yours. And if they are, and if you've been on the fence or thinking about cannabis, then maybe this could help give you more information to reassure you or potentially just be that thing that makes you want to give it a go. But I have no motive. Like by no means does anybody have to try cannabis. It's just, information is knowledge is power, basically. And so just being aware of it, and it may not be the time. Like maybe there's still other medications you're titrating that you want to complete, and that's totally fine. What are the side effects of gabapentin? Don't want to go too down this rabbit hole, but I've seen patients have leg swelling, so pedal edema, swelling in the feet. I've seen people with gabapentin have sedation, confusion, trouble with memory. Trying to think what else I've seen with gabapentin. I've seen like one patient was on a really high dose and became psychotic, but that was only one patient. But these side effects I'm describing are pretty much the same for everything. You can find a case report for nabilone causing psychosis. You can find a case report for an opioid causing, all these things as well. So yeah, just to remember when a medication's working on the nervous system, dizziness, drowsiness, all of these things are quite common with these medications. Somebody's asking, do you use nabilone and cannabis together? And I would say no. So nabilone is covered under most prescription drug plans. So it is a way, if cost is an issue, to use it. However, THC is very cheap because the oils and the plants, we can dial it down to a very small dose that a bottle might last you 3 months, 6 months, depends on how much you take. So it's quite cost effective. And honestly speaking, I do find the plant works better than nabilone. And I think the reason is that the plant has THC, CBD, it's got some CBG, CBN, all these other cannabinoids. And I think the combination of all the cannabinoids together, like the plant is smart and it makes it the way it does for a reason. That I think there's something about the experience versus just taking one of those molecules, which nabilone is just THC, and it can be a bit intense for people. So I'd like to say that I do believe the plant is better, and it's totally fine to start with nabilone as well. A lot of my patients, when they travel, they'll get a prescription for nabilone because if they're worried about crossing the border, nabilone is allowed in the US, for example, and in other countries. Somebody here saying they did try nabilone and it did help with pain, but it made them so anxious. And so I am very curious as to what dose that was. I would guess it was 0.5 or 1 milligram. It could be 0.25, the lowest dose. But again, this is always dose dependent when you have side effects with THC or nabilone. So sometimes you can compound nabilone and have it in a liquid and use it even at a lower dose. Somebody's asking about THC, if it can help with back pain and sleep. Yeah, it can help with both at the same time. And actually, nighttime is the perfect time to treat those symptoms because you're already asleep. THC can cause sedation. And so if it helps you sleep and it helps the pain, and then when you wake up in the morning, you feel refreshed and the pain is better, then your daytime pain may be under better control. And so I have patients that only use THC at bedtime and they don't use anything at all during the day, not even CBD. And so for cost effectiveness, that's a really great strategy because CBD is more expensive. Now you can take smaller amounts and it's less expensive, but just to say the cost is usually around CBD. Somebody said with THC, they had the munchies, and I've heard that as well. Again, it's usually dose dependent. And yes, we do need to be worried about or concerned or aware of weight management issues. However, in all the patients I've seen, I would say 95 or 98% stay the same. So it's interesting because the endocannabinoid system is involved in homeostasis of the body in all these different areas that I showed earlier in this presentation. And I think because it works in homeostasis, if you're a bit overweight, I've seen people lose weight and I've seen people underweight gain weight. I've had a couple of patients with anorexia do really good with some cannabis. In particular, they started with CBD, but I think it was really the THC that was helping them there. And they were just less anxious about the weight issues. And I've seen people overweight lose weight. So, I think it might have been because if I was helping their pain, then they could move better. And they might have had some weight issues because they weren't moving better. Also, if you are depressed, sometimes you eat more, emotional eating. So it's interesting. I think that THC can help with mood and sleep and pain and all these things. And then you just might naturally be losing the weight on your own. It's possible. Somebody's asking about lidocaine for pain. So yes, it has been used in dental procedures. I mean, obviously freezing for acute pain, acute trauma when we're cutting a wound or stitches, we use it. For chronic pain, I've seen it used with sort of dry needling, trigger point injection. It's true. I worked at a clinic and doing the change pain clinic where I did some trigger point injection. But honestly, I found trigger point TPI to be just as good with dry needles without injecting as people have reported with lidocaine. I think it's the action of cutting, the needle actually cuts micro cuts in the fascia. And I think that for some people, their fascia is just crunchy and tight and scarred for so many reasons. I could talk for an hour about fascia. I don't know if anybody's already done that. I love talking about fascia. And I personally had a very deep journey with fascia. And I have done so many things that yeah, I'm sorry, the time's just getting tight here for people here at shift change here at the hospital. So yeah, so fascia is a really important conversation to have as well. But being very mindful, the fibromyalgia patients that I treated with trigger point injection, when I first began, I actually caused flare-ups and I didn't mean to, but what I've learned over time is when you're really sensitive, making a lot of changes, you think the first day after they feel great, they can move so well. And then 3 days later, they're stiffer. So I learned a lot with you need to use magnesium and so many other agents to support patients. They need to be able to move. If they get in a car and have to drive for hours or not be able to move, it can actually, trigger point can actually flare things more than help. So it has to be the perfect patient profile for that. I don't recommend it as quickly as I used to, and it's still a good tool. Is it safe to use CBD and THC while taking amitriptyline? Yes. Oh, it's only a really small dose of amitriptyline too. Yeah, absolutely fine. It's different than Ativan. So yes, you could do that for sure. If you're nervous, start with CBD. It contains a little bit of THC, and then you can go slowly there. Just noticing the time, we've got a couple more. Can cannabis help tapering off medications such as amitriptyline? Yes. We'd first want to get you to the right dose and to make sure your symptoms are controlled before we would start taking away a medicine that can have side effects. Because when you taper a medicine, you might find that you have withdrawal, and I would hate for you to feel worse before feeling better. Can cannabis increase the chances of opioid overdose? So it's interesting because the studies have showed that the patients, when they take cannabis with an opioid, that's why they cut back on the opioid, is because they feel the opioids are working too well. But funny enough, when they do the blood draws, the levels of opioids aren't any higher. So there's something, interesting between how they work that we can't fully quantify. So I'm cautious when I start it. I tell people to drop their dose if they feel too sedated. But I haven't seen a case report where the cannabis has caused the opioid overdose. It's usually blatantly the opioid dose was quite high. Okay. And Any studies using cannabis as a muscle relaxant? Yes, definitely. Mentioned that earlier. Cannabis and cognitive issues. I'm seeing Dr. Arsenault jumping on here. Just I'll finish this last one. Cannabinoids and cognitive issues. So THC, just like anything, can, if it's too much, it can make you a bit foggy, a bit confused, memory, all those things. So this is why we start low and go slow. And so there was 87 questions there, and I don't know how many I got, but hopefully for the majority, we got some of those through.
Thank you so much for another great presentation. So Dr. MacCallum and I will be in contact, and we'll set up another couple sessions like these. And do you want to ask for topics beforehand, or do you want to?
Yeah, I think it would be helpful to hear what everybody's wanting. And when I hear that it's overwhelming, I think it's because I only had 2 sessions and I was just trying to like give it all my best. And so if I know I've got more time, we can
Yeah.
take the time and then go slower. I think that makes sense for everyone.
So when we send out the slides deck, we will ask the question of, do you want to suggest the topics yourself, or do you want them to suggest the topics?
Maybe I'll put a few in the email of like things that are commonly requested just to get,
Yeah.
the juices going. And I think that when they look through the slides, they might have more questions as well. I've seen both.
The other thing that we've done with Gaetano, naturopath,
Yeah,
is
yeah,
we've done a session that's just 90 minutes of Q&A.
yeah, yeah.
We and that,
I could,
and that one we don't record because
mm,
we allow people to kind of talk, and so that could be one presentation as well, just an open Q&A.
I was thinking about that when you shared that you also do medical visits where you're doing medication management. And to do that, like you really need to be able to hear somebody. And like,
Yeah.
I don't want to, I need to be careful with generalizations because people may take what I'm saying and change what they're doing. And then, it's not good. So I agree. You need more time for that. And sometimes structure's good to have like even 5 slides to start off. Like, let's start with a theme and then we can tease it out.
Perfect. So everybody, we have a
Amazing.
plan. Dr. MacCallum will be back. And again, thank you so much. Great
Thank you so
presentation. Have a
much.
great week, everybody.
Thanks, everyone. Thank you for bearing with me with the background. It was a last minute thing. Apologies. Take care.